Hello. This is the story of a man with complex medical problems who came into hospital to have a nephrostomy due to an acute infection. He ended up with having a small dose of succinylcholine, a drug that paralyzes you for a few seconds, when he was back on the ward after his procedure. This should not have happened. The HSSIB, or the Health Services Safety Investigation Board, investigated this and came up with an elaborate breakdown of the various reasons why this happened. They highlighted some common drawbacks with processes within hospitals for this kind of procedure. In fact, what they did was to articulate very well what the problems were, and they provided a very comprehensive structure for the things that actually went wrong. In this episode, I will explore some of these issues that the HSSIB discussed in great detail. I will try and break them down and provide some context from the anaesthetist point of view about why, without meaning to, we end up in situations where mistakes happen and patients come to harm. In this case, it is important to say that this patient did not necessarily come to any physical long-term harm, but the few seconds of not being able to breathe left him with very heavy psychological trauma. To summarize what happened, this man in his 40s was meant to have an urgent nephrostomy. The term nephrostomy comes from two Greek words, nephros meaning the kidney and stoma meaning mouth or opening. So the term nephrostomy literally means to create an opening to the kidneys. In this case, it is safe to assume that there was probably pus around the kidneys and the patient needed a stoma to allow this pus to come out and thus help with his recovery from the kidney infection. The procedure is done by specialists who are called intervention radiologists. So basically they're radiologists, and with the help of X-ray, ultrasound or CT scanning, they put in a tube that connects the kidney to the outside. And this is done in what's called the intervention radiology suite. Now therein lies the very first complexity in the whole process. Normally, in most hospitals, there are only a few sessions scheduled in an IR suite, which will have an anesthetic team. Often not that many, because most of the procedures can be done either awake or with a bit of sedation, which is managed locally by the radiologists and their team. In the case of this patient, as this was a complex case, he needed a general anesthetic, and that too at fairly short notice. Now, what happens in these situations is that a team often gets put together. Now, if I got a request like this, I'd have a look at my staffing levels in operating theatres and see if there was anyone completely free, which doesn't happen very often, to send down to radiology. The next best thing would be to see if there's a senior registrar who can carry on with cases in a particular theatre list, and the consultant can be freed up to go down and do this case. It looks like in this case, this is what happened. A fairly experienced consultant anaesthetist was found, as was an ODP, which is an operating department practitioner. Think of them as anesthetic nurses to go and facilitate this nephrostomy. So we've now got an ad hoc team which has been put together to go to an environment which is not considered home turf. Now, what do I mean by that? Normally in theatres, anaesthetists are very familiar with the layout of what lives where. The whole workflow is very predictable. The anesthetic machine is in a fixed place. The drugs, the labels, the cannulae, everything is within reach. In the IR suite, however, they'd have to start from scratch. So if you think about the cognitive load, there is a whole layer of processing power being used up before you can deliver what you need to deliver to the patient. This is subconscious, obviously, but there's something going on in the background. Now, if these guys did this list every single week for a few months, this cognitive load will come down drastically. This is not dissimilar to anesthetic trainees rotating every 6 months or so from hospital to hospital and getting to work in newer environments and meeting newer people every few months. And I've always thought that this is actually quite a positive to the rotation. Yes, it's a bit unsettling because you have to move hospitals, but I think you get a lot to learn from that. But then once you are a consultant, you become set in your ways. It gets harder and harder to adapt to newer environments. You simply lose that practice. Anyway, this was the backdrop, and the team did go down for the afternoon, let's say for a 1 p.m. start, which is when most afternoon lists would start. Now, frustratingly, they then had to wait another 90 minutes for the patient to come down from the ward to the IR suite. And at the time, at 1 o'clock, they don't know that they're going to have to wait for 90 minutes. They were expecting the patient to come down pretty much immediately, but he didn't. There's a bit of annoyance and frustration because these guys have been uprooted from what they were meant to be doing for the day and moved at short notice with a sense of urgency for this case to come down to IR, and obviously they're now happy. So they called the ward after half an hour or so of waiting and were told that the patient had been held up because he needed bloods doing before they came down for the nephrostomy. Now, this patient had complex medical problems, and in patients with complex medical problems, repeat hospital admissions, cannulation, drawing bloods, they can be often quite tricky. In this case, it took the ward doctors, who usually are very, very junior doctors, it took them about 90 minutes to draw this blood and get the blood sent off to the lab. What they did do very helpfully was they put in a cannula into this patient, and this cannula was what a variety called non-ported type. So they left the cannula in considering the IV access problems that they'd had with this patient, and this kind of saved the IR team a little bit of time afterwards when this patient came down to radiology. But as this delay was happening, there was other things that started being considered and factored in by the team downstairs in radiology, which was the fact that this radiology suite shuts at 5 o'clock, and the question of where does this patient go afterwards to be recovered from their anesthetic. Normal processes usually for intervention radiology would be that they'd have a little recovery area where a nurse would come down from recovery, cover this patient, and send them back up to the ward. But as there'd been an hour and a half's delay already, the question of where's this patient going to go up later on came up. So anyway, the patient came down, and that cannula which the ward doctors had put in came in quite handy. The patient wasn't fasted adequately because I'm guessing they decided at short notice that nephrostomy was the way forward. And in such cases, we do something called a rapid sequence induction of anesthesia, which is essentially drugs given in rapid succession to first anesthetize the patient and then place a tube in their trachea. And this is done to minimize the time between loss of consciousness and a tube going down into your trachea to prevent contents from your stomach, which are quite acidic, going into your lungs and causing damage inside the lungs. So the drugs that were used were fentanyl, propofol, and finally saxamethonium. Now, a little bit about the details here. First, the cannula, which, as I mentioned, was a non-ported cannula, which essentially means that there isn't a separate port on the cannula to connect a syringe and deliver drugs. So as a result, a small length of plastic tubing, about 5 centimeters or so, is connected to the cannula, and this has got a bunger at the end, which is like a stop, to which a syringe or tubing from IV fluids can be connected. Now, because there's a bit of space between where you connect the syringe and where the cannula is, there is potential for drug to stay in that 5 centimeter of tubing. Usually this is normal saline because the routine practice is to flush it with saline and leave it free of any drugs or blood. Sometimes the extension tubing is split into 2 or even 3 different arms, each of which leads to the cannula, so it's like a splitter. And the second detail I want to talk about is the thing I mentioned about the potential for a drug to live in that tubing, and that's normally normal saline. Now, this patient in IR, they first had fentanyl, then a bit of propofol, and then saxamethonium into the cannula extension. Now, immediately as the sux goes in, the focus shifts onto the airway during an RSI, which is the rapid sequence induction. This report, interestingly, doesn't mention anything about the presence of a second anaesthetist, so I'm guessing that the same person, the consultant, injected those drugs and then walked across quite promptly to the head end of the patient and take over the mask from the ODP, because the patient has to be breathing 100% oxygen for about 3 minutes before the drugs go in. So at this point, the ODP will be also applying what's called cricoid pressure, which is to compress the esophagus and prevent stomach contents from coming up. Within 60 seconds, the patient will have small twitches of muscles known as fasciculations, and once these have faded, the anaesthetist will go on and intubate the patient. So in this case, they secured the airway, proceeded to insert a second cannula, presumably a bigger cannula, into the patient's other arm, and then proned the patient. Now, proning the patient is basically getting the patient to lie on their front. So the back is at the top, and that is to facilitate easy access to the kidneys for the radiologist, because that's where they will be working on. Proning is usually a 4 to 5 person job and involves a significant mental and physical workload, all whilst making sure that the tube that's just been inserted doesn't come out. So it can take up quite a lot of your mental space. Now, the anaesthetist injected the drugs, and clearly their focus shifted first to the airway and then to then to cannulate the patient, and then they got involved with proning the patient. So you can see that in all of this, it's quite easy to forget that there was a bit of succinylcholine left behind sitting in that IV tubing. From here on, the entire event was fairly uneventful. The patient had the procedure. Towards the end of the procedure, the ODP had to negotiate with recovery in main theatres to get them to accept this patient afterwards. And then once the patient had recovered completely, they went back to the ward. What happens on the ward? Well, the patient felt a little bit unwell, perhaps got a bit of sepsis, a bit of temperature, and he got seen by someone from the parent team, which in this case was a urologist. The urologist prescribed the patient IV antibiotics, intravenous antibiotics and intravenous paracetamol to bring the temperature down. Nurse tried using the new cannula. It didn't seem to work. It may have got displaced, or it could have just occluded. So one of the nurse's colleagues advised the patient to use the other cannula, the non-ported one, which had been originally put in on the ward, not knowing, of course, that this had a little bit of succinylcholine in it. And lo and behold, this got flushed into the patient. The patient then really struggled to breathe, had just enough time to bring attention to himself. Luckily, help promptly arrived. The patient got ventilated for 2 or 3 minutes, and succinylcholine in a small amount would wear off quite quickly, which it did. And the patient sort of was able to breathe on their own after this. So this was a sequence of events, and we've touched upon some of the factors that were involved in where the patient ended up receiving succinylcholine and felt the way they did. The HSSIB report goes into great depth, like I've said, and analyzes many different factors, which we will look at in the second part of this episode. See you then. Bye bye.